Today we are going to discuss tricuspid stenosis, that is the narrowing of the tricuspid valve. Before we go on to the subject itself, we see the jugular venous waveform. You see the jugular veins have three positive or upward deflections and there are two downward deflections. Now we see what are these upward deflections and why these upward deflections are produced. Now first one is the A wave. Now why this A wave is produced? This A wave is produced because of the atrial contraction. Keep in mind the atrial contractions occur at the end of the diastole, the ventricular diastole. So the atrium contracts and the pressure starts rising in the atrium. So this wave reflects a pressure rising in the right atrium. So A wave in JVP is because of right atrial contraction. Similar tracings can be seen in left atrium as well, but we need invasive testing to document those waveforms. They are similar to this waveform. There is a slight bit of pressure difference. But we are going to see what are these waveforms in the neck veins which can be clinically examined. So the A wave is because of the atrial contraction. The atria contract, the blood is ejected out of the atrium. And then the atrial diastole starts, atrium relaxes. Now, when the atrium relaxes, the pressure in the atrium falls. Then there is another reason for falling pressure in the atrium, because when the atrium is relaxing, at the same time the ventricle is now started contracting. So the right ventricle contracts and has a little bit of pull on the right atrium. So the right atrium enlarges further, so the pressure drops. This is called the X descent. Now this X descent is interrupted by a small wave which is called a C wave. Now why this C wave is produced? Because as the ventricle contracts, the tricuspid valve moves back, it closes, and this backward movement of tricuspid valve produces a slight bit of wave in the course of this X descent, which is called C wave. So the A wave is because of the atrial contraction, the X descent is because of the atrial diastole, atrium is relaxing, and C wave is because of the closure of the tricuspid valve. When it comes back, it causes a slight bit of rise in the atrial pressure. And then when the atrium closes, the blood is coming from the inferior and superior vena cava. It is now filling the right atrium. The right atrial pressure starts rising, so you get the third positive wave, that is V wave, is because of the passive filling of the right atrium. And when this is filling, and the systoles and the diastole starts, the ventricle relaxes, the tricuspid valve open, and the blood rapidly moves into the right ventricle. So there is a Y descent. The A wave is because of the atrial contraction, the C wave is because of the closure of the tricuspid valve, and V wave is because of the passive filling of the right atrium. The X descent is because of the atrial relaxation, atrial diastole, and this Y descent is because of the ventricular filling during ventricular diastole. So the blood is moving out of the atrium into the ventricle and the pressure falls. So you have to understand this waveform to understand the clinical phenomena which are going on during tricuspid stenosis. Now the tricuspid stenosis, the most important reason is rheumatic heart disease. This is post-traumatic heart disease, but keep in mind rheumatic fever does not cause isolated tricuspid stenosis. There are other lesions as well. There may be aortic or tricuspid lesions may be present. Then other very uncommon causes of tricuspid stenosis include congenital atresia. There may be right atrial tumors like left atrial myxoma. There may be a right atrial myxoma. Carcinoid syndrome. Carcinoid syndrome most of the time produces tricuspid regurgitation rather than tricuspid stenosis. And then you've got endomyocardial fibrosis, large vegetations which are present in patients who are IV drug users. These vegetations, if they're present on the leaflets of tricuspid valve, they can result in stenosis. And then you've got connective tissue disorders like SLE. They can produce it. Now you see only less than 1% of isolated cases of TS are seen among the patients who've got valvular cardiac lesions. And you see most of these tricuspid stenosis lesions are associated with either a mitral valve lesion or a aortic valve lesion. So isolated cases of tricuspid stenosis are really uncommon. And when we do an autopsy on patients who've died of rheumatic heart disease, we find that 15% of the patients have tricuspid stenosis. There is a slight bit of female preponderance, but when we see clinically, only we see 5% of the patient have some significant tricuspid stenosis. Otherwise, in most of the patients who got tricuspid stenosis because of rheumatic heart disease, usually it's not very, very significant. Now, what pathology we see is just as in mitral stenosis, we see there is fusion and shortening of the chordae tendineae. The valve leaflets are joined together. The edges are stuck together. Then there is dilatation of the right atrium, and there is a little bit of hypertrophy of the right atrium as well, depending upon the chronicity and depending upon the pressure gradient between the right atrium and the right ventricle. Now, there is a rising pressure in the right atrium. When this pressure gradient is more than 5 millimeters of mercury, pressure gradient means the pressure in the right atrium and the right ventricle during diastole, when the pressure in the ventricle falls to almost zero, and if the right atrial pressure starts going beyond 5 millimeters, so this is a time when clinical features start appearing. That is, when during diastole the ventricle is relaxed and the pressure in the ventricle is very low, it's approximately zero, and the right atrial pressure, which are again normal people, they are close to zero. If these pressures starts rising and goes beyond 5 millimeter, symptom may start appearing. Symptom may be patient may have fatigue, patient may have edema, there may be ascites, and you see the jugular distension also starts at the same time, and this jugular extension is augmented by inspiration and salt and fluid retention by the patient. Now, what are the symptoms? As I mentioned, the symptoms are number one, fatigue, because patient has lower filling of the right ventricle, so the right ventricular output is low, hence the left ventricular output is also low. So the patient has low flow, that's why patient may start experiencing unusual fatigue. Patient may have abdominal discomfort because the patient may have congested hepatomegaly, which may cause a pain or dragging sensation in the right hypochondrium. There may be ascites with abdominal distension. There may be some pleural effusion as well. Patient has generalized edema as well. The shortness of breath, the orthopnea, these are rare in isolated tricuspid stenosis. Usually these patients have associated lesions which may produce these symptoms, but the main symptoms are fatigue and abdominal discomfort. Some patients report neck discomfort, but it's not reported by many patients. Physical examination, we go for a general physical examination. We find patient has dependent edema. There may be in some patient pulsatile hepatomegaly. The high pressure in the right atrium sometimes is transmitted backward into the vena cava, and this pressure may go into the liver. This may be a large liver, and you may feel the pulsation of the livers. This pulsation is seen in diastole because the atrial systole occur in ventricular diastole. Then you may find features of involvement of mitral valve or aortic valve, and you may find the corresponding murmurs of mitral valve disease or the aortic valve disease. Then you go for the examination of the neck veins. You may find a prominent and full neck veins. There may be a prominent A wave. And if the patient has atrial fibrillation, this A wave disappears, because this is because of the atrial contraction. And in atrial fibrillation, the atria do not contract. So therefore, an A wave is not produced. The Y descent is slow because the valve is stenosed and the blood cannot leave the right atrium very rapidly. So the Y descent is a little slow, and the slope is more prolonged than rather than having a sharp slope. Then on precordial examination, there may be splitting of the first heart sound, there may be single second heart sound, because the right atrium is not contracting very forcefully because of the poor dilatation of the right ventricle. So the second heart sound may be single. There may be tricuspid opening snap, may be audible in some patient, and there is a mid-diastolic rumble at left lower sternal border, which is different from the rumble of the mitral stenosis, which is seen at the apex. The murmur. This murmur increases with inspiration because the right-sided events are related with respiration. If you raise the leg of the patient during squatting, sustained hand grip and amyl nitrate or in right lateral decubitus position, the murmur's intensity increases. Then it also increases in Muller's maneuver. Muller's maneuver is actually exactly opposite of the Valsalva maneuver. What we do in Valsalva is that we exhale against a closed glottis. We use force exhalation against a closed glottis. While in Muller's maneuver, what we do is we ask the patient to close both the mouth and the nose, and we ask the patient to inspire against a closed nose and a closed mouth. So this is exactly opposite of Valsalva maneuver. In Muller's maneuver, the murmur increases while it decreases in expiration and the straining phase of Valsalva. Now the differential diagnosis includes atrial myxoma. There may be effusive constrictive pericarditis which can cause a rise in JVP, endomyocardial fibrosis, restrictive cardiomyopathy, tricuspid atresia. These are different differential of patients who present with tricuspid stenosis. Then we investigate, we can see in addition to the general investigation like CBC, renal function testing, liver function testing, serum electrolytes, the blood sugar, we go for the testing for the involvement of the tricuspid valve. In the ECG, we may see there is a right atrial enlargement, that is, there are tall P waves in inferior leads, particularly lead 2. Patient may show features of atrial fibrillation. A chest X-ray may show right atrial enlargement, especially in the lateral view. Echocardiography is a very useful test which can tell us many things. There is diastolic doming of the leaflets, there is thickening of the leaflet, movement restriction can be seen on echo. Then the Doppler echo shows the prolonged antegrade slope, that is related to the movement of blood from the right atrium into the right ventricle. Catheterization is generally not required for tricuspid stenosis. It is required in older patients when we are considering that there may be concomitant presence of coronary artery disease. So we evaluate for the coronaries as well, because if the patient requires surgery, coronary evaluation might be required, and if needed, CABG or coronary artery bypass grafting can be done at the same time. Then from catheterization, if we're planning surgery, we can see valve area, the pressure gradient, and the presence of associated effects which can be seen on catheterization. So in those patients, we may go for catheter studies as well. The management is divided into general management. General management is salt and water restriction. You reduce the sodium intake and the water intake so that the fluid load on the body is less. The symptoms, they tend to improve. Then we can treat the atrial fibrillation if it is present, and we can go for the treatment of infective endocarditis if it is present. Surgical management. Surgical management, when we go for surgical management, if the pressure gradient, the mean pressure gradient between the right atrium and the right ventricle exceeds 5 millimeters of mercury, or if the valve orifice area is less than or equal to 2 centimeter squares, the tricuspid valve has become smaller. The area of the valve has become smaller, we can go for surgical management. And when we go for the treatment of tricuspid stenosis, try to fix all the coexisting lesions as well. For example, if there is a mitral stenosis or if there is aortic stenosis, that should be addressed at the same time when we are managing the tricuspid valve. Now the surgical treatments are of two types. The most favored is nowadays we go for a valve replacement. Bioprosthetic valve can be placed. This valve is usually preferred over mechanical valve because of the risk of thromboembolism. But the life of the metallic valves is more than the life of the bioprosthetic valves. One can go for open valvotomy, that is to create a bicuspid tricuspid valve. What tricuspid valve has 3 leaflets, anterior, posterior and a septal leaflet. What we do is we can go for opening the fissure between the anterior septal and the posterior septal regions. That is the fissure between the anterior leaflet and the septal leaflet, posterior leaflet and the septal leaflet. And we do not open the commissure between the anterior and posterior leaflets, but because that results in severe tricuspid regurgitation, which may not be tolerated by the patients. Now there are devices in which instead of an open valvotomy, we can go for a catheter valvotomy as well. So these are different treatment options available for tricuspid stenosis, and next we will discuss tricuspid regurgitation. Till then, goodbye.